Any questions?
Go ahead.
Sir, most common complications with the silicone implants?
Which one? Which one?
Fat.
Submental.
Buccal fat.
Where is the hollowing?
In case there is hollowing.
You can never have hollowing. The patient is always wants more. I don't know. मेरे में तो बोलता है और निकाला क्यों नहीं?
Next question. Yes.
Sir, most common complication with silicone implants?
Probably once in a while there could be infection, but I don't know. I have not faced anything. That's all.
And cost of the implant, not the procedure.
Cost of the okay, so it depends on the companies again. So chin implant would cost anything between 15 to 17,000, and bilateral cheek implant would cost anything 22 to 25,000.
Silicone is better, peak implant is better. Peak implant.
Yeah,
Very expensive.
No, it's not very expensive, sir.
Very expensive. Again, you have to take a CT. You have to make this thing, send it to the guy. He's going to sit with you, design.
See, the quick fix is the silicone implant, but the peak, you need to properly follow the protocol, get the DICOM done, get the peak implant fabricated. Yes, it is the closest structure to bone, so it lasts longer. And I've got a couple of videos in the next one I'll show you. But the fastest one is the silicone implant. Chances of infection.
So okay, now if you want to do an angle, for example, if you want to augment the angle, you can't do a silicone because it's not going to sit there. So you'll have to take a DICOM file, send it to the guy. He's going to design it, kitna banana hai, and then you're going to be printing it, and then you get.
But micropore has shown some results of infection. There are studies of infection because it's of.
Sujesh, we'll come to that. We'll come to that. We'll quickly start with the Trilogue, sir. And there are set of questions which after both of your presentations I became both happy and confused. So now we'll discuss about that Trilogue, right? So first off, identifying the right candidate. When evaluating a patient, Dr. Atre, for a facelift, what are the ideal indications do you see? Are there specific aging classifications that guide your decisions, or say somebody coming up with some body dysmorphia or anything? How do you classify the patients?
So first of all is understanding the patient. You can't just take the patient up and go and do a facelift and think, the questions later. Counseling, understanding the patient, spending time with the patient. I give them a good amount of time to think about what we are doing. Maybe come back, take a couple of sessions and then come back, and then we decide. And how they're going to look, we discuss that. Ideal patient, if you're talking about, patient, these days we see a lot of youngsters getting facelifts done. Those are not my priority. Anyone who does not have too much of a tissue sac or
Sir, any imaging or any just for the PGs?
So we have something known as AI based analysis that we do. We have a device for that. We can even show some amount of befores and afters to the patient, how they might look, but it is all AI based, so it is not confirmatory. So we have a consent form also for the same, so telling them beforehand that when we do this imaging, that maybe it can be something on those terms, but it's not going to be short on those terms.
Like we spoke about, that there are 3D cameras.
Yes,
that
we call it the
three-dimensional.
Opatra. We have it. It's called the Opatra. Very few of them are there in India. We have a device for that.
So what do you look at when you look at these procedures that you spoke about? Very interesting procedure, Arun sir. Then what do you look into that? For evaluating a patient for any kind of a surgical aesthetic procedure, any evaluation that you go in for?
Actually, these are all
just for the PGs to know that, because certain procedures have to be done under local anesthesia. Not everybody would directly go into a facelift. But what is a prelude to facelift? How do you really assess the patient for that?
Facelift or this other adjunctive procedure?
Adjunctive procedure.
See, I personally feel it is the patient's requirement. So the patient, some patients are very happy with the, for example, sunken chair. Kuch bhi wo log, they say, no, I am happy with this. So I personally feel that it is what the patient wants. That's what and imaging and all anyway doesn't have any role in this. But I personally feel it is all what the patient wants and how the patient wants to look. I mean, मैं कैसे कपड़ा पहनना चाहता हूँ मेरे को पसंद है. So that kind of thing. That's what I personally feel.
So that would be the next question. Facelift versus neck lift. When to address each, Dr. Atre?
When to
address each? Like, are there any isolated cases of neck lift that you would want to do?
So when there is collapse, there are a lot of young individuals who have undergone drastic weight loss. Okay. In these instances, you see a lot of tissue accumulation in the submental area and the neck area. So yes, youngsters with a lot of loss of fat, lot of excess tissue, maybe an individual neck lift. But even if you want to do an individual neck lift, you will have to go pre-tragal as well, because the entire tissue needs to be resuspended, just like what I mentioned. You can't just leave the tissue in thin air. You have to resuspend it with a stable base, just like what I showed you there also. So even if you have to do the neck, you will have to find a resuspension point, either the posterior angle point, or you need to go up to your zygoma as well. You have
सर
to
एक पेशेंट है सर, वो कह रही थी कि खाली आत्रे सर और अरुण सर से ही ट्रीटमेंट करेंगे. कैन आई ब्रिंग हर इन मैम? कैन आई ब्रिंग हर इन
प्लीज?
कैन आई?
हाँ प्लीज. अरुण सर आपके लिए अच्छा पेशेंट. ये ढका हुआ क्यों है?
सर लखनऊ से है ना, पर्दा करती. So sir, just for you, what would you go around, what would you plan for this case?
Tell her to speak and tell me the problems. Yes, what is your problem?
Sir, she was telling me that she wants to look pretty.
She's already pretty.
But sir, that's not what she
Lucknow
says.
Lucknow
Lucknow
से
says.
तो pretty है. क्या लगता है? क्या करना चाहिए?
Okay, the first thing if you see, no, the brows, they are, I think they are sagging.
Can you lift her up as in sorry?
Sir, if we were to discuss it in the way that upper 1/3, middle 1/3 and lower 1/3, how would you address that?
Okay. So basically,
Surgical or non-surgical?
Sir, we can discuss surgical only.
So basically, see, average age of this patient, if we are taking it at around 45 or something, right? Can you see this? Can I keep it here only?
close up
The face
और
is
उठा के रखना है. ठीक है? दिख रहा है? Okay. So 45 going on to 50, something around that. Very rightly said. Always start with the upper third, middle third, and lower third of the face. Upper third, if you can see, the skin laxity has come into picture. The muscles are dynamic, wrinkles are already visible here, but the brows have actually given way. He's absolutely right. There is temporal hollowness here. The entire upper third has collapsed. So what you need to basically do is you need to plan for probably a brow lift here and lift the brows up to make her look younger. For dynamic wrinkles, there is no other option. You have to give the toxin to reduce the dynamic wrinkles. Yes, we can put in some amount of fat there as well to give some amount of reduce the skin laxity. It is actually going to help with the concept of myomodulation. When we talk about the mid face, sir, you want to put an implant?
Yeah, definitely.
So, I would actually, my basic thinking is instead of just putting an implant, I would want something which will sustain a little longer rather than putting something, a foreign body. Yes, if the patient says it's a very good option to put a mid-face implant and a chin implant. But for me, if you ask me, I would rather do a mini lift, just a SMAS lift up the SMAS, resuspend and put fat there. So no foreign body, autologous, lifting up the own tissue layers. And at the same time, maybe something for the jawline as well. Because if you imagine, sir, please forget it. Or thank you. So basically, when you lift up this entire tissue, this entire lower third will also lift up to the mid face. It is a basic concept. Whether you talk about mini lifts or any kind of a lift, if I lift up the mid face and you all go and stand in front of the mirror, when you lift up your mid face, your entire jawline will also lift up vertically. So yes, resting all this on the mid face, so we have to treat the mid face no matter what you do, and the dimples and the brow as well. This will make the patient look younger.
Say for example, sir, can we have a combination procedure? Can we do a brow lift and also do a cheek implant?
Yeah, why not?
We can do that.
Why not?
Actually, many a times what I have personally seen is if you augment the mid face, the patient looks very happy and the patient looks very young. So this is what. But another
And
thing is
chin.
Chin.
Always treat the chin. When you see the nose to chin
Sir,
angle.
that brings us to the next question.
Oh.
That is enhancing the jawline, addressing the totus and the deficiency.
So the jawline has two parts to it. One is a bony part and one is the soft tissue. Soft tissue, we have spoken enough what we can do with the soft tissue.
Right.
But what can we do with the bony part? Dr. Arun just showed us that.
Sir, both of you got me confused because in that small discussion, we spoke about augmenting the chin with a silicone implant. Sir was wanting to do it intraorally, and you had a proponent of doing it from extraoral approach.
I might not put an implant. I might like to do a conventional
So, sir,
xenoplasty.
as a youngster, and you being the master, tell us what is the better pathway to this surgery. If a patient walks into a center, would you want us to do it extraorally or intraorally?
Depends from doctor to doctor as well. But yes, if you look at the old school of thought that they never. First of all, in silicone implants, have you held a silicone implant in your hand?
It's pretty soft, sir.
How soft?
So it's a
Pretty flexible, right?
It's a bit flexible.
So my concept is, if I'm doing it intraorally, I have no option. I have to put in screws. Or even if I do mid-face implants, I have to put in screws.
Yes.
But if I just make a small tunnel on submental, probably just a 2 centimeter incision, which with my suturing will not be visible at all. And I just tunnel it up right below the mental, and I can go through subperiosteal dissection to wherever I want. All I need to do is just tuck in my implant, just suture it with the muscle and leave it there. It doesn't move at all. That is because I have not created a major vestibular incision.
Right.
And at the same time, why I don't do it? Not that I'm against it.
Right.
I might do it at some point in time.
Right.
I've done it for a few patients, but this I'm very comfortable because I don't need to put in the screws. Those screws will compress that silicone implant. You can press it like this, that silicone implant. But if it's peak, you have no option.
And sir, how huge will be the scarring? Like, does not the scar the
When I
entry
say
point?
1.5 centimeters, who's going to come down below and look for
Right.
that 1.5 centimeters?
And this you can do under local anesthesia also?
Plus, it is done in the local.
In the local
It
anesthesia.
is done in the local. It is a very straightforward. Plus, if the patient is so concerned, 6 months later, you just give us fractional CO2 2 sessions. That's all.
Great.
It's done.
Arun sir, your points.
So the thing is basically the problem is when you kind of placate it with any muscle there. The first thing is extraoral approach. You cannot reach way up here. So if you want to augment it anteriorly, I find it very difficult because with this small incision of say 1.5 2 inches, it becomes very difficult for me to reach here and also go to the lateral sides if I want to kind of widen it. For example, a male patient who is there, so he wants to have a wider chin, so it becomes very difficult to laterally go and actually to see where exactly you're going to be putting the implant. I mean, maybe I am not surgically so efficient. So, but that's my personal feeling. So when you do an intraoral, it's very simple, you reach there. Now coming to the part that should we be fixing it or not. So there is a study of 2023 wherein they have reviewed 1051 cases of chin implants, and this thing says the prevalence of fixated versus non-fixated facial implant, the amount of population, blah 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 blah, and it is saying that moreover fixing a facial implant using hardware requires more surgical preparation, yes, setup and all those things. This is significant. So the overall complication rate, what they're saying is in terms of resorption, there has been seen that if you fix the implant with screws, the chances of resorption is much lesser if it is not fixated. If you want, I will just forward you this.
So resorption of what? The
Resorption
implant.
of the bone.
But
Bone resorption.
silicone, why will the bone resorb? We're not compressing too much.
No, so basically it is said like anything which is rubbing against the bone,
Micro movements at all.
micro movements.
Can we talk more about the incisions, please, the approaches?
Yes.
and
So
the
incision is very simple in
Yeah,
intraoral
that we've
vestibular.
done.
That's
That
it.
we've done. So
And
next question.
So that brings us to the next question to you, sir. In the last of your presentation, you made us go through certain angle corrections, and you made us look at it as a cakewalk. But I know I've tried a few BSSOs and all that. It makes me cry when I reach the angle. How do you make it look so sweet? Please tell us your approach.
The gonial angle.
Gonial angles.
Okay, so morning we discussed the incision. You put a kind of an incision on the labial vestibule, extend it on the anterior border, and you reflect the whole of the ramus with the masseter. So you have reflected the whole thing. So now you are able to see the whole of the ramus till the lower border of the mandible, and also you are going to be seeing the gonial angle. Now the most important thing is, how do I know how much of a gonial angle we have to reduce?
Exactly.
So what I do in my cases is basically I do a pre-op CT. CBCT is good enough. You take a DICOM file, send it to the guy. 800 rupees you can get a model, 3D model.
Scale model, yeah.
Always get a 3D model.
3D model,
Sterile
right?
lift.
So on that, what you do is your dental lab who is there, you ask him to make a small, जितना कट करना है उसको एक वैक्स बना के उसको दे दो कि मेरे को इतना कट करना है तो ये वैक्स बना के दे दिया. So what he is going to be doing is that part, like for example, I want to cut like 3 millimeters or 4 millimeters or 5 millimeters all along from here. So you take that wax part, put it on the model, and you give it to the lab guy. So the lab guy, like how they make a crown for you, so they take that that wax and then they put it into the thing and they'll give you a metal thing. So now you have a metal in your hand which you can put it on the lower border. So now you know that this is here. So your piezo is going to rest on the top part of the on that metal thing.
Right.
So you can't go down. You just can't go down. You know that मेरे को यहाँ कटवाना है.
So basically, you are working it like a cutting guide.
That's a great idea. Great idea.
Very simple.
Very
Okay,
nice.
next.
So that brings us to the next question, that is combination approaches. We have already discussed a few of them, but what are Atre sir, some take home messages for the PG as per a facelift surgery? What can be your take home messages for the PGs?
See, there is a learning curve when it comes to going on to soft tissue surgery, and particularly when we talk about facelift surgery. It is there are a lot of combinations here that work together. So how can you start? How you actually need to start is by understanding the aging pattern. Till the time you don't understand what is the aging pattern, what is happening, why this patient requires a facelift, and then going into your soft tissue skills, enhancing them, understanding what kind of a facelift, what kind of a soft tissue procedure might work for this, what kind of other adjuvant procedures might work for them. You saw so many different procedures today. It's not just facelift. It is about doing the small things but doing it right. And then you combine it. You should know what will work for what patient and the ideal patient. So basically getting on to understanding the aging patterns, the aging process, and then what treatment plans will work for each. I mean, that is how you will have to start.
I have one questions from each one of masters. One question from Panda sir. Panda sir, you told dimple creation. You are taking suture outside and then skin incision. Can we done from internally everything?
So that's what I was telling. So what you have to do is you have to take one bite from the lower part of the mucosa and the muscle, and then now imagine your needle has to go from all those tissues, fat and all those things, and you're going to be taking a bite on the dermis. It's going to be a hell of a job. You understand the small incision of, say for example, half an inch, you're going to be putting your in. How do you know where I'm tying my dermis or not? You will be struggling and struggling and struggling and struggling and struggling to lick the face. So
next question from Facelift sir. You are giving that horizontal incision that's near the hairline. Why it's necessary? We can go from like behind like that.
How will you lift? How will you lift if you go
We
post
can
auricular?
dissect it and lift.
Where are you lifting? Your mid-face lifting is all going to happen above your sarcoma. If you go post-auricular, where is your lifting going to happen? You stand in front of a mirror.
No, I will explain it. So, one second. See, the thing is probably you're not understanding that we have to cut that skin and we have to take it up. It is just not about dissecting.
Yes, it is not just dissecting, it is resuspending the excess tissue also. So how much of a hairline you want to dissect and cut and resuspend? Your tissue excess you will want to reposition in the temporal, which is a short scar technique, or into the hairline. This scar will not see. It will not be visible at all. You just created a new hairline, a new side bun for the patient, just like what you saw with the patients as well. It heals beautifully. Basically, your soft tissue skills. If you are able to give a good soft tissue result to the patient, all this settles down very easily.
Okay. No, we'll have to break
Just
now, sorry.
one, ma'am, just one question. Sir, some concluding.
Done. Yeah, what is your question?
My question is that when you're taking the trailers, if you are visiting during facelift and you have to cut some sort of excess tissue along the mirror line also, then how do you make sure that the tragus is back?
That is where you will have to train well, because if you should be able to know where your tragus is going to rest.
Is it better?
It is all excess tissue which you are cutting and repositioning. You are not going to come close. You've obviously got a cuff of almost 2.5 millimeters close to your tragus. So you just putting the excess tissue, cutting it, resuspending it, rechecking, reconfirming at least 3 times before you cut that excess skin and muscle, and then resuture.
Okay, I think we'll have to break. I'm sorry. Please,